And that brings us, if you will, to the use of insulin with type 2 diabetes, because when I was in medical school, that just wasn't done. Then it became acceptable. Now it's considered great treatment. So somebody start me off on this. When is insulin needed in type 2 diabetes?
Well, insulin is needed when the glucose control is not satisfactory, is not sufficiently controlled, despite the use of oral agents. You know, the recommendation says metformin, all the different orals, and the other option, basal insulin. I don't think people do it for the most part. People will use 2 agents and sometimes 3 agents, but if the A1C is above 7 or 7.5, I think that it's time to consider insulin, and I agree with Carol that we should do it much, much earlier. That's where the really game changer came with the use of insulin glargine, because with the insulin glargine became very simple with 1 shot a day, slowly starting with 10 units. When the decision was made to start 10 units, there was no science with that, because it was very simple to use, titrating with some hypoglycemia, but much less hypoglycemia than NPH.
I think the use of the pen was an amazing advancement, which is, it's continued today with the combination therapies, and that was the first time we started to use pens regularly.
I think it's important to recognize insulin deficiency. Someone with a very high A1C, 10, 9.5 and above, they are insulin deficient, and you can give all the other drugs you want.
You're not going to get
It's
much.
an exercise in futility. You need to give a small amount of insulin to help those drugs work better, and they work very well in combination.
So what is early insulin initiation, and who gets early insulin, and what are the benefits of going on insulin earlier rather than later?
Well, if we looked at all these studies of insulin initiation, most of these studies testing insulin glargine, detemir, NPH, degludec, U300, you looked at the demographics, you look at 10, 12 years of diabetes. It's not about in time. It has to do when it was determined what the A1C is. If the A1C that was individualized is about what the patient and the physician wanted, despite the use of oral agents, it's time to use insulin. And that's early.
Yeah, I would think some of our reasons for delaying the use of insulin, for making it further down, has been because the previous insulins were so difficult to use and were so associated with complications and were not very effective. However, that's changed. The insulins that we now have are very effective, long-acting, basal insulins, rapidly acting analogs are very effective. And so that's allowed us to move the insulins earlier in the game. But in the past, insulin was always the last. And it was the last because it was the most difficult to use. But that's not the case today.
We also have pens with finer needles. It's a lot easier for the patient.
God.
It's somewhat unfortunate that you often find patients on formulary, the insulin is covered, but the pen is not.
Yeah.
And I think that's really tragic, because the incremental cost of a pen is very minimal.
So I think the issue of early insulin administration, Julio talked about the fact that insulin is what's missing. They've done studies with even pre-diabetes and early diabetes and giving them insulin glargine, and the main reason for doing the study was a cardiovascular outcome study. But what we found out from that, if we start patients within 5 years of their diagnosis of diabetes, we can get their A1Cs below 6 and keep it at around 6 for 7 years. 1.5 kilograms of weight gain over that 7-year period of time. Very low rates of hypoglycemia. So if a patient has endogenous insulin secretion and we're just supplementing it by giving a little extra, they can tolerate it very well, and all of the baggage that goes along with diabetes or with insulin therapy is much less when you use it early. So I always tell my residents, insulin is never the wrong answer. If you ask what we should do with that patient, insulin is never the wrong answer. It might not be the best, but it's never wrong.
No, but just to follow that, sure. Carol is referring to the Origin trial that tested insulin glargine versus no insulin. And over 6 years, these people actually started very early, had cardiovascular disease with a baseline A1C of 6.5%. They went over 6 years, and the A1C at the end was like 6.3, 6.4. So, insulin works very well, and those are people very well controlled. Some of them even have pre-diabetes and accepted the 1 shot a day with a relatively low dose.
By the personalized goals that we talked about earlier, you wouldn't actually use insulin in those patients.
Of course
Yeah.
not.
But that's the point, is just trying to make it that the earlier you use it in the course of diabetes, the better tolerated it is for the patient.
So help me out here and help our audience out. There are patients in whom early insulin is a great idea. So why don't you tell them, a typical patient walking in the office, who would you start insulin on early?
The patient who has cost issues, I would use NPH insulin after metformin.
I would not use NPH insulin. I think that now with the biosimilars that have come down, the insulin glargine, I think, is the way to go. And even the other one, that is the glargine U300 or the degludec, those are more expensive, but I will use the biosimilar.
The cost is the expense. So if I have a patient who has good insurance, I'm going to probably do an SGLT2, GLP-1. I'm not going to get to insulin right away, but I'm just saying that there is a consideration. NPH insulin is very effective.
Yeah.
The treat to target study, no better A1C with glargine than NPH. The problem was nocturnal hypoglycemia.
You know,
they
there
get
are
a little
some,
bedtime snack.
There are some healthcare organizations that still use NPH.
They will, yeah, I can't get.
But one thing that Bob Henry said, that we have better insulins and so on, that we have faster acting insulins. I myself think that short-acting, fast insulin is way too complicated for the family practitioner.
Totally agree.
I think that when basal insulin is not enough, what we need to be using is a GLP-1 receptor
I
agonist.
agree with you. I agree with you.
And I heard you say something that
In
surprised
type 2
me,
diabetes.
which was insulin's expensive.
It is very expensive.
But that goes against everything I thought about insulin. To me, insulin's old, off patent, easy.
This is a
Ancient,
recent
ancient.
phenomenon. The price has gone up in the last 5 years
tenfold.
tremendously.
Why?
Well, the Congress is investigating it. I don't know the answer.
So the reality is that there are, middlemen now between the pharmaceutical companies and the patient that are taking a substantial amount of cuts from the cost. That's part of the issue. But the reality is all the insulin analogs that have come out, they are better insulins. There's no question about it. But the cost has been such that you can have a patient on a kind of average dose of insulin, and it's as expensive as some of these newer drugs we've been
So
talking
let's-
about.